one here. It's about use of cardiac CT. Number one, in an asymptomatic patient at intermediate risk already on a statin with other risk factors controlled, should cardiac CT be done? What will it add? Question mark. Sorry, Sebastian.
It still, I think, this goes back to the slide where I said where the calcium score could play a role. I think it's really for risk stratification of the patients. So if the patient is asymptomatic, you do a calcium score, you get that the patient is above the 75th percentile of his age group, then for sure the patient is still, although he is already treated, warrant for an invasive test like a cath examination to really exclude any flow-limiting stenosis. And I think this is the role or the edited value of the calcium score and the CT we could bring for the patient's care.
Maybe a quick add-on. We know that Sebastian has shown that we have this 40% of patients that are in the share of the intermediate risk. And calcium can tell you or help you bring it to a really low risk or a high risk. And high risk is more than 20%. That's like you have diabetes or you have already had a previous event. It's in the same risk category. So it's kind of clearing. You will not be able to bring any of these patients, or all of these patients, out of this category, but you are able to lower down the share, which is in the kind of gray zone. That's the benefit of calcium scoring. So there's an add-on question to this one, also for low risk, but early family history. Will cardiac CT help decide statin therapy? Calcium scoring, yeah, well, that's depending on what result we're getting. Essentially, it's recommended in these patients' populations. Sebastian, you want to add on that? So once we have a low risk, but with family history,
yeah, again,
calcium scoring?
Again, the same thing. If the patient himself has no real risk categories from the Framingham risk assessment score, but there is a family history, so a genetic predisposition for development of early atherosclerotic changes, it might help you to really risk stratify this individual patient with the least negative side effects. So the radiation dose is, I think, the minimum what all the other tests Bernd showed provide, and we still get a fair idea what's going on in terms of atherosclerotic plaque burden in this individual. So this is where the calcium score can play a role, really individualized risk assessment with the least harm to the patient.
Okay, next one. Does the oral calcium tablet digestion at regular dose increase calcium coronary artery disease risk?
Sorry.
Does oral calcium tablets at regular dose increase coronary artery disease risk?
Not that I'm aware of, that this is the typical metabolic pathway for these tablets.
Okay, so I have only questions for Sebastian, so let's gotta bring up some other questions. We are talking about patients' risk, and radiation is really one of our, let's say, not problems, but things we've faced with the patients quite often. And last year there was some discussions going on about after this paper, I think it was from Quebec, about this cohort study where they said, okay, patients with this and this interventions, which was not including cardiac CT, but other cardiovascular interventions, that they have a higher risk of cancer after that. And the question is it really supported or not? There's some studies out there about radiation dose. It's hard to justify and talk up to a patient, hey, the risk is the same as you smoke a pack of cigarettes a day. So how can we assure patient and also the referring physicians, which is the majority of the group in here, that it's the risk-benefit ratio. In case there's a huge information we get out of a CT scan, you can also take a higher risk, but it's really hard to really talk to a patient about that. Is there any advice you have on that?
Well, again, I'm not a physician and I don't deal with patients clinically, but I do deal with a lot of the public who have these same fears: Fukushima, Tokamura, Chernobyl, and it's all about the radiation dose. I think it's important to be, honest about the risks with the patients, but you don't want to what you don't want to do is go down a path of overemphasizing any potential risk of radiation, because again, none of the risks have ever been established below 100 millisieverts. And it's interesting, you know, I was thinking about this over lunch. If you look at high dose areas, you know, in Canada, we're getting about 3.6 millisieverts in a year. If you lived in Kerala, India, you could get upwards of a couple of hundred millisieverts in a year. And in fact, there are large populations that are living in these types of natural background radiation environments, and they show no excess mortality over and above what we're getting. So and if you go to Ramsar, you can have areas that are approaching half a sievert per year. And again, no excess mortality. So, you know, when you look at say a normal radiograph that's 10 microsieverts, it's almost laughable, really. I mean, it's not a laughing matter, but it's almost laughable. But you know, my opinion is to not overemphasize it. Say, if you're getting multiple procedures, we want to track this dose. If we're up above 2 gray, there may be deterministic effects that we want to monitor and treat the symptoms. But again, don't dwell on it. And what you're going to end up doing a lot of the time is, unfortunately for us in the radiation protection industry, the most vocal people are the anti-radiation people. And those are the people that are going to be on the internet that, you know, your patients are going to Google, and that's the first thing that's going to come up, all these horrible risks. And I tell my students the same thing. 9 times out of 10, what they find on the internet is 100% wrong.
I just have a quick question. Is there any part of Toronto that has a high background radiation that you should know?
Well, we're kind of sitting on the whole continental shelf here, so I guess you've got your dose of radon for those of you who have the $900,000 condos, penthouse suites, you're okay. So,
where did Barry go?
Just don't live in the basement.
So you mentioned one of the problems is we always get the bad news in the media, and the media is the education for our patients. We never get anything that's stating, hey guys, yes, there's a risk, but it's by far different from what has been published. So only this interesting stuff is taken up by the media. Maybe just, I mean, you know that Sebastian and myself are coming from Germany, and you mentioned, Ed, that radiation protection, think about radiation in Europe is at a totally different level. In Germany, essentially, the radiologist can say, okay, no, we're not doing this test, because the final indication for a test, especially for CT, can only be taken by a radiologist. So it's always a discussion between the clinician and the radiologist. I think, although it's not a mandatory thing, I think that's the best thing to discuss in case, yes, I have a patient with these problems. It doesn't only apply to cardiac CT, it applies to everything on CT, abdo, chest, and whatever. Does this test really give me the information that helps me changing management or reassuring that nothing has to be done? I think that's the most important thing we can discuss with you as the referring physicians and also with the patient in terms of, yes, do we go for it or not?
I think the most important thing with discussing risk is to prepare yourself and be firm in what you know. And that's why I said, is it safe? Yes, it's safe. Don't sit on a fence and don't say, well, you know, in this case, maybe, and not. It's safe. As long as you've done a justification and an optimization, it's safe.
Thanks for this clear statement. Any other questions? I thought there were kind of hundreds of questions for Diraj coming up. It was actually...
It was a very productive lunch, so...
Okay, what do you mean by productive? So you answered all questions, huh? What was the majority of questions you got answered?
So the majority of questions focused around who the appropriate patient was to have this treatment performed. And the other set of questions was around, beyond that, where do we see the technology going? What patient groups do we see it being used in? So if I did a quick summary, refractory hypertension, 3 medications or more, blood pressure is not controlled, that's what we're sticking with for now, with no known renal artery lesions.
Short question. You said it's easy for the interventional radiologist or cardiologist. What about patient pain? Is that A painful procedure?
Patient pain is mainly parking fees downtown, but it's actually patient pain. The procedure takes 45 minutes. It's a percutaneous procedure. There is a fair amount of pain during the procedure, which we deal with some conscious sedation. No patients really need general anesthesia. Actually, none of them do. And there is no pain after the procedure. So you go home pain-free. So the actual pain related to the procedure is only for about 6 minutes, which is controlled.
Do the patients need to wait how long after procedure? In the milieu or so?
The standard recovery time right now for us is going to be overnight as a precaution, but otherwise 6 hours.
It's overnight parking cost.
So basically, yeah, which will be a really big pain. But they would come in, let's say, at 6:30 in the morning and go home potentially at 7 or 8 o'clock at night. Okay. Simple day procedure.
On Monday morning, I think they got a lot of calls about patients who are not following the treatment. But it's not going to you directly. It's going to nephrologist, hypertension specialist first. And well, in case you couldn't write down the number, I think he's happy to give the number again later on. Any more questions?
There was a question, yeah.
Would this be something good for women who have maybe not 6 medications but volatile hypertension before they want to have their kids?
Potential, but totally unknown right now. Another question in the back.
Yes, Dr. Richard. Nerves have a way of regenerating. If we haven't actually sectioned them, what do you think? We permanently dysfunction these nerves? Like putting them in this manner?
Just repeat the question.
So the question is related to nerve regrowth and whether this procedure temporarily interrupts the nerves and then they regrow at a later time. So 2 years out, we're seeing a sustained response. So up to 2 years, there's no regeneration, but correctly said, we don't know what happens 10 years from now. I could only tell you to 2 years.
But like PCI could be redone.
Or you could image them with 12 different modalities and still not understand what's happening.
Thanks. Any other questions? Yeah, on the left.
A National Geographic question. Could you just do a brief overview of the high areas of the world? You described these giant, low, and where are
Yeah, absolutely. Well, Ramsar, Iran, extremely high. It's one of the highest areas in the world. There are some areas that are not highly populated, but populated up to 700 millisieverts per year, total dose. Give you an idea, we regulate to 1 millisievert per year. Kerala, India, again, 200-300 millisieverts per year, highly populated. Guadalajara, Brazil. There's another place in China, again, orders of magnitude greater than what we get in North America. Even if you go from here to Colorado, because of the altitude, you're getting more cosmic radiation. You're an order of magnitude. Just to give you an idea, interestingly enough, over lunch I was talking to the people at my table, and I went to Chernobyl in 1999, and I was doing some work in the exclusion zone, and that's 13 years post Chernobyl explosion. And I was wearing a dosimeter my entire time, an electronic one. And just for fun, this was in the pre-9/11 days when you could actually take kind of strange things on aircraft. I got onto the plane in Boryspil, turned on my dosimeter, reset it, turned it on, threw it in the overhead bin, and the flight from Boryspil to Montreal was double the radiation that I got from a week in the exclusion zone in Chernobyl. That's from cosmic radiation at 36,000 feet. So if you're wondering if airline pilots, they're trying to be reclassified as nuclear energy workers and badged.
There's one thing also in terms of, let's say, CT, medical imaging, radiation exposure, it's coming down to a small number of patients often. I mean, a lot of patients get repeat scan ICUs, whatever, and they have these very high dose radiation dose, and it's averaged over the entire population, of course, so that we have this high rank and the lower radiation dose to the individual patients. There's another question. Yeah, sure.
Well,
yeah, we start here. Yeah, go ahead.
Could you give us an estimate of how many units when you are doing a bilateral mammogram? Or any extra, just to have an idea to fit it in that 100 per year, 100.
Yeah, well, a mammogram, I believe, is right around 0.1 millisieverts, 0.15 millisieverts per exposure.
The bilateral.
Yeah, I believe
Well,
it's right around then.
That's a good data to give to the patient.
Yes, absolutely.
I mean,
Yeah.
that kind of figure, I think, would be very useful.
Yes. Yeah, and it's usually when I'm talking to my physician friends about this, there are resources, and if anyone's interested, I can send them to you that compare the different procedures, compare the dose, and you really see, you're talking 10 microsieverts, on a chest X-ray. It's very, very small. I'm actually more concerned when I look at the cohort about the actual people that are doing this, the physicians that are doing this, because they're being exposed over and over. And the problem is their doses get sent to the National Dose Registry and they get smeared out amongst all the other radiologists. So, if you have a bunch of 7s and 3s, the average is 5. You might never have a 5 in there. So really, we don't have a good idea of these, of the interventionalists, or the people that are getting the higher dose because they're smeared out with the lower dose people. And I'd like to see these dose categories broken up so that when they're reported, we can actually track the higher dose groups. That's my personal opinion.
So we got one last question from the back here.
At the risk of being redundant regarding the issue of screening with CT9 score, the issue talk indicated that it's not recommended by guidelines for asymptomatic screening. Yet the implication was that if you take an intermediate or high risk asymptomatic individual, you can indeed downgrade them by risk. With this strong negative.
Just to clarify. In asymptomatics, the calcification is recommended once you're in the intermediate risk group. That's for the asymptomatic. In a symptomatic patient, the calcium score, I think Sebastian has nicely shown you that it doesn't really add on information. It is for the non-symptomatic individual, not a patient yet, who's in the intermediate risk group. Then the calcium scoring gives you information, how old are your coronaries? I mean, is your coronaries at the age of 40 as old as a 70-year-old guy? Then you're probably in the higher risk group, or you're still young on the coronaries like a 20-year-old guy. That's the add-on information. I think we're all set. Thanks for your participation, and we're going to go on with the next session.